Podcast 6, Enhancing Practice Value-Based Programs. So Larry, in a previous podcast, you shared the importance of physician engagement in value-based environment. Can you expand on that?
That's probably one of the most important things that we struggle with on a daily basis with our physician practices. And April's in these offices every day, and she sees it even more than I do. But when we talk about value-based care and we talk about these different cost-quality metrics, it's important that the leader is the physician. And if the physician doesn't buy into the engagement of these programs, then the staff isn't going to buy into it. And that's where it becomes so important that we have that physician engagement in this and understanding how the physician can in fact impact their financial well-being with all these different programs that we provide. You want to hit on that?
That's an excellent point, because value-based IQ really needs to be a culture in the practice. It does need to be the way that the practice operates as a whole, and the leader is the physician. Absolutely.
So how could a physician staff better position the practice in this value-based environment?
Education, education, education.
We have, we've developed this value-based IQ program, and we also give our physician practices a monthly and quarterly scorecard of all the different things, whether it's cost or quality, it's their ER visits, are they good based on the market average and the ACO trends, or are they're an outlier? And we show them where their strengths are and where their weaknesses are, and we try and help them put together a plan to improve. All with the indication that they're engaged and agreeable to make these things happen in-house. Because, the old way of practicing medicine, you see your patient, you bill it, and they leave. And if they end up in the ER or the hospital, mainly sometimes the physician doesn't even know about it. Well, we have all those tools in place now to keep them completely educated on what happens to their patient even outside the walls of the office.
And taking it a step further too, so we also try to identify who are the frequent flyers going to the emergency room. We'll find that there could be 1 to 5 patients that might be going to the emergency room once a month or something to that effect, but yet the physician isn't really aware of it because they're showing up at the ER, they're getting whatever their prescription is, they leave. So we educate them. So the next time the patient comes in, the physician and the staff can have a conversation with that patient to say, if you're having an upset stomach, or if it's your sinuses or allergies or something, did you know there's a freestanding urgent care center 2 blocks from my office that can see you and will also contact me on your behalf, and then also you can follow up with me either the next day or something like that. But it helps the patient because they're not paying these huge out-of-pocket costs, and they get better care.
In our analytics, we give our physicians a number of different algorithms and analytics, and we'll tell them what your main admissions are, whether it's low back pain or like congestive heart failure or COPD or upset stomach. In fact, I think that was
migraine.
It was intestinal issues was one of our big ones.
Yep.
And we try to identify those patients within that group and come up with programs to manage those chronic illness patients. Because the bottom line is, of the $4.6 trillion that we pay for healthcare today, 85% of that care, it's documented, can be delivered in a non-hospital environment at a fifth of the cost. But yet 75 to 80% of the care delivered in America, particularly acute care, is delivered in a hospital environment when only 15% of that care would need to be. So think about your premium as an individual and what you pay for your family for health care and how you could impact those dollars, whether it's through your employer or through your own personal health care plan, as far as what you pay for those dollars. I mean, today, a family of 4 on an HMO, a restricted health plan, has approached $2,000 a month.
With a $5,000 to $10,000
deductible. And that about a $5,000 deductible.
Right.
When you look at the Affordable Care Act, Most of those plans, if you make more than $40,000 a year, you don't qualify. Yet, if you're an individual, you're going to pay $800 to $900, maybe even $1,100 a month for your premium, and you got a $5,000 deductible at $1, so you have no coverage other than catastrophic care at hospital care. It's about anticipating illnesses and managing chronic illness so it doesn't turn into an acute care position where you end up with a $50,000, $100,000 hospital bill. And that's what independents are all about.
So what tools does the IPN provide to assist with this?
Okay.
Well, we do have a lot of different payer contracts like commercial shared savings, Medicare Advantage, that are paying or offsetting reimbursements to a shared savings bonus type of structure. But I think we also provide tools that help them with the education, which is initially the biggest part, is education. The physician needs the education to then pass to their practice and staff. They need that education, the staff, to practice then to their patient population. Everybody needs to be aware. I think consumers in general are not aware of the costs because they feel it's, I get sick, I go to the doctor, and I pay my copay. And it really isn't that simple anymore. It's moved more into where I think consumers have to play a part of it so that we can all try to work to keep that healthcare dollar down. But we definitely work with different entities like the UCF Health Arch, College of Medicine.
Mm-hmm.
They are fabulous at doing education on
Care gaps.
improving MACRA and MIPS and patient-centered medical home, which is a huge push today. So I think those are some of the best tools that we provide as the resources for the physicians to obtain the education.
Great. So Larry, how would you summarize this?
The financial well-being of a physician is the most important piece. But today, with all the pressures, whether it's against the hospital, whether it's against payers, whether it's against all the regulatory entities, or even the consumer, they have to be able to function within a financial environment that's stable. And we try to provide as many of those as we can, and we provide the tools and the programs for independent doctors to compete in today's healthcare environment. And I believe that IPN is in such demand today with 11 counties, over 1,500 doctors, and inclusive of that is almost 475 primary care doctors. And we are seeing more and more. We've got national organizations that have indemnity plans of 300, 400, 500,000 lives that are coming to us wanting to rent our network because they know that what they're doing currently with a major payer is costing them so much more money than they should be paying. And our whole goal is to not only improve the financial well-being of a practice, but give them the tools and the capabilities to compete tomorrow when value-based care is even getting more important than it is even today.
Thank you for that great information.